right, so we're going to talk about patient education, management of treatment expectations, some of which will be literature-based and some of which will be anecdotal. So first I'm going to go over hope versus reality and kind of talk about what our position is as the clinicians that goes along with the marketing and advertising of our institutions that we work with. And then we'll talk about some patient expectations, especially about treatment efficacy and safety, and then how we relay that to patients, some patient education, and then this serious illness conversation guide, which I'm not going to overlap with Dr. Temmel, who's going to do more about shared decision-making at end of life. I'm going to talk about this more from a perspective of earlier in the game and talking about therapy and as a patient-centered model. So I look at this as that there's two main strategies to this. We can look at data, and there is data on this from patient and provider studies. But the second part of this, and probably the most important part, is that this is an art. This is getting to know your patient and having a relationship with them. No matter how different that patient may be from you, there has to be some kind of relationship to have these conversations. So this was my hope versus reality and why they collide. So I'm going to date myself a little and say that when I was growing up, the two main people on Wheaties boxes were Michael Jordan and Mary Lou Retton. I turned out to be neither of them, even though I ate Wheaties. I sprinkled honey on mine, so that might be. My dad always it tastes better with honey. So I'm like, oh, maybe that's why I didn't become them. But this is kind of, we deal with this a little bit in the cancer world, and we all know that Wonder White bread didn't necessarily build strong bodies unless you probably put chicken or peanut butter on it. And then I love the doctors smoking cigarettes. Probably not the most true ad campaign that's out there. And then these are the marketing slogans of very large cancer centers in the United States. So this is kind of what we're dealing with. So the cure is within. I'm not going to name the cancer centers, but one of them is mine. Making cancer history. Cancer, nice try. When cancer invades your life, you want a miracle. That's probably my favorite. Because if you read these, it's looking like you have cancer, you're going to see a provider who's going to give you a miracle, who's going to make sure the cure is within you, so we got to get that out of you somehow. And we're going to make cancer history, so you won't have it. So it's kind of these things that put us in a little bit of a difficult situation when the patient comes and sees that on television and is like, okay, good, this cancer center is going to make my cancer cure or go away, and using these words. So this is the first study I'm going to present to you before I get into the nitty-gritty of things, and this was a fairly new study looking at new novel therapies and when we should stop. So this study looked at patients, and 57% of patients had no idea, and this was the terms used. They had no idea or were unclear what PFS means. So this is going to be repeated over the studies I'm going to show you. Don't say the word PFS to your patients, and don't say progression-free survival, because they don't know what it means unless they're in the medical field and really probably even within clinical trials. So those words are not helpful to patients because they don't know what it means, and that gives them complete unclear or no idea of what's going on. The other thing was, from a physician standpoint, in this study, they were asking physicians about what the actual therapeutic gain was from, a treatment regimen they were giving versus the actual published data. And I laugh about this because there was actually a discrepancy between it. And if you got in our clinic on Tuesdays, it's Corey, Tracy, Josh Baumel, we're all sitting in the room, and we can go in that room and say, I just saw a patient with stage 3 lung cancer, we're going to give them concurrent chemo-rads. And I'll say, well, Tracy, what did you tell them their 5-year survival rate is? Or what did you tell them? And it might differ 5% from what I might have told them, from what Josh or Corey might have told them. And there's clearly published data on it, but it's like, did I say that it's 30%? Or did I say it's 25%? Or did I say 35% if I was feeling really strong that day about my etoposide cysts and radiation regimen? So, even in that, we may tend to bias towards a higher number than what it actually might be if a patient asks us. And that was actually true in this study. The other thing that this study showed too was that there's newer drugs with less toxicities, and there's more options for us now than when I started doing this so many years ago. So that kind of gives us, well, when do we stop? This more came up with immunotherapy, I think, is that, well, it's really not toxic, and we have this option when it was first approved. So we kind of were giving it to patients where otherwise we may have put them on hospice at that point, just because we have more options to choose from now. All right, let's talk a little bit about managing patients' actual expectations of the therapy. So this was a study that looked at Prognosis Understanding, and this was a large study, 686 patients with metastatic lung and colorectal cancer, and they were surveyed 3 to 6 months after their diagnosis. And only 16% of patients knew their accurate prognosis, and that was defined as if you had lung cancer less than 2 years. So that means that only 16% of them thought they had less than 2 years to live, which was absolutely true. So the majority of them didn't have an understanding. Now, the only thing I'll say in defense of us as clinicians on that is if a patient doesn't necessarily say, Beth, exactly how many months is my prognosis for overall survival, I'm not going to come in and be like, well, it's nice to meet you, Mr. Brown, but you know you have less than 2 years to live. You know, I don't necessarily blurt that out, and that's not necessarily the right thing to do. But it's unfortunate that only 16% knew that that was kind of the ballpark that they were living in. This also found out that the earlier prognosis was discussed, the more understanding was reported, and I think that's going to be seen over and over with studies. This is a study that Dr. Temmel is going to talk about as well. She's going to talk about a different part of it, but this was a really important study, huge, almost 1,200 patients with metastatic lung cancer and colorectal cancer, looking at the patient's expectations for the treatment they were going to get. So 69% of patients did not understand that their chemotherapy was not curative, and that kind of goes along with my last slide. So a lot of patients did not understand they were not being cured from this, even though they had metastatic disease. I thought the one important thing here was that education level was not at all a factor of misunderstanding their diagnosis. So you can walk in apparently and say, your cancer is not curable, and you can have a third-grade education or a PhD, and it didn't matter because that statement was understandable. So education level was not a factor. The funny thing, too, about this was that you had a higher likelihood to think your chemo is curable if you rated your physician favorably with communication. So apparently people like it if you tell them their cancer is curable or if they think you told them that. I hope that doesn't go the opposite way to say if I tell you your cancer is incurable, you're not going to like me as a provider. So we have to find a way to have patients still like us, but be able to tell them their exact prognosis as well, or at least that their cancer is incurable. Okay, so another study looking at lung cancer patient preferences. So this was a lit review of 20 different studies. And unfortunately, they still found that, and I don't want to say unfortunately, but this is just patient preferences, that life extension was still more important to them than health-related quality of life or side effects of their treatment. So when it all comes down to it, patients still are looking for life extension at this point as their number one preference. Now, they did say in the study, though, the older you were, especially elderly age 70 and over, still were more likely, though, to choose quality of life over extension of life. So it seems the younger you are, that extension of life is going to be, and that makes a lot of sense. So, okay, so what do patients actually understand when we're talking to them? So this was interesting because most patients in this study actually they understood their diagnosis. Yes, I have metastatic lung cancer as opposed to early stage. 81% understood the treatment procedure, so this is going to be chemotherapy that's going to go in and try to kill my cancer. But only 42% understood that the treatment intent was palliative versus curative. So again, that same thing, patients not understanding the treatment goal here. Again, satisfaction with the treatment goal was much lower than satisfaction with the other two, where they understood. So they were not necessarily satisfied if they thought this wasn't going to cure them. So same theme kind of going on. So how do we manage these expectations? Well, this was, again, surveys, and these were the factors that affected the patient satisfaction about their expectations for therapy. Again, simplifying the information was number 2. The first one was level of honesty and how they felt you were being honest and straightforward. But number 2 was the simplification. So remember, no PFS, no OS. Don't say these words to them because they're not going to understand it. Probably I would avoid saying like big words like bevacizumab, or I mean, you could say the word, but then don't keep repeating it because they're just going to get caught up in what the heck are they talking about. You can say treatment instead sometimes. And then again, you see down at the bottom that provision of hope. So even though we're telling them this is something incurable, use the word hope. It's okay to say, I hope this is going to work, and I have a lot of hope that we have therapies that we can manage this for you. And I have a lot of hope that I'm going to help manage your side effects. They love that word. So this is anecdotal. So when I was asked to do this talk, I was like, oh, I'm only going to find, certain literature for this because I'm going to not do end-of-life discussions this year. So Corey said, well, Beth, just talk about what you do. And I'm like, okay, I can do that. So I think this is the art part. this is the art part, reading the patient and the family while you're in the room. So while you're having your visit, what are they looking for? What is the family looking for from you? I think you have to disclose the curable versus incurable. This just has to be disclosed. It doesn't have to be, like I said, you're not going to live to 2 years, but or you're not likely to live to 2 years, but just you have to disclose that part of it, because unfortunately, if they think that it's curable, they're going to be planning for 10 years down the road, and that's probably not something that's realistic for them. I think discussing the chances of a therapy working is also important. Again, not saying PFS or words that they're not going to know. And maybe not exact numbers, but this is what I would say. And I happen to use our very best data, which may not be, as explainable to all patients, but the actual data for first-line pemetrexed, carboplatin, and pembrolizumab, and this is as of ESMO update 2017. So the actual is response rate of 56%, PFS of 19 months, and 57% responding at 1 year. How I would explain that, because I'm not going to use response rates, PFS, or numbers, so how I'd explain is you actually have a good chance of this regimen that might shrink your tumor or your cancer. And chances are, at a year, you might still be on this regimen, but not always. So, don't necessarily say, yeah, you probably will be, but not always. This is averages. And then I like to say, on average, somewhere between 1 and 2 years, we might need to switch this if something isn't working. So that's very honest with what the actual numbers are. Now, I thought to myself when I read this slide, I'm like, all right, that's not going to be every patient. So let's talk about the worst case scenario, which would be extensive stage small cell. So if I had a patient come in, extensive stage small cell, and they say to me, so what do you think about this treatment? What do you think about this chemo you're giving me? That's what they always say. What do you think about this chemo? Have you seen it work for someone else? So what I would say to them is that, well, unfortunately, this is not something that's going to make your cancer go away. It's not something that's going to cure your cancer. We're going to try to give you this chemo. And a lot of times, this chemo is going to work at first because it's small cell. So a lot of times this chemo is going to work at first, but unfortunately it has a very likely chance of reoccurring pretty quickly. And at that point we hopefully have other treatment options if you're still feeling really well that we can give you, but unfortunately those treatment options don't always work. I hope that they will, and I'm certainly going to try my best to give you every opportunity at treatment, but unfortunately this is a pretty advanced disease, and we're going to do our best to treat it as best as possible. And that's probably how I would explain it. Using the word hope, aligning yourself with the patient and what their goals are and what they want, but at the same time still getting in there to say, unfortunately, this is an aggressive disease, and we didn't use any numbers. If they ask, I'll give them. But if they don't ask, I don't have to necessarily say it. But we did tell them it's something we can't cure. And I like to say, make go away. I say we can't make this go away. And I would be open at the panel discussion for any other key terms that people may use. So let's move on. Patient education and communication. What factors are important to patients? This was a lung cancer study that 54% patient received disease-directed stage-appropriate therapy. The caveat of that is obviously that 46% of patients did not receive the proper therapy for their stage, which is kind of scary. The higher probability for appropriate treatment for these factors was when the risks of treatment were explained, the chance for cure was explained, and I love the last one. Remember, warm and friendly. This is what counts for patients. They want you to be warm and friendly, and they want to view you as a, caring and hopeful physician. So patient support groups, I was asked to touch on this in one of the slides, and this is really hard in lung cancer patients, more than any other cancer. So traditionally, lung cancer patients attend support groups much less than any other types, and this was actually a survey and a study that was done. And at the time of this study, only 1% of lung cancer patients were actually actively attending a support group. And my navigators are sitting in the back, and they can attest to this as well. We have tried to develop support groups at Penn, live support groups where patients actually attend. And the barriers, I did all those. I got their parking paid for. I was having food that was going to be there. It was at time after work in case that was an issue. But we never could make them work. I only tried twice. I think you guys have probably tried, also. But this is hard. What they found in the lung cancer group for support groups is that online support groups are much more positive, or there's better enthusiasm for it. So I put up a bunch of them. So the first three, Longevity, Free to Breathe, Lung Cancer Alliance, really are good places to send all of your patients, not just for support groups, but for information in general. But they do have a subset of the website that patients can use as an online support group. The next one, the Patients Like Me, is not just lung cancer. That's actually for not even just cancer. So you can go on this website and then put your disease type in, and then you can find online support groups and blogs for that type of disease. And then the last one I hesitated to put in, but I put it in because it is branded by pharma. There's no drug mentioned on it, but there is a company logo on one corner of it. So it is branded in that degree. But this is only a support group for patients. So unlike the other ones where none of them are lung cancer specific, or the top 3 is support groups of only main side part of it, this is just a support group for lung cancer patients. And it's actually very well attended. I've been on the website, and patients can get really involved in this. So it's just another opportunity for them to be part of a support group. And again, I don't know if this is a stigma thing where patients don't want to attend a support group because of the lung cancer. Oh, you smoked, you must have deserved this. And they don't want to show their face at a support group. So maybe that's why the anonymity of online might be better for lung cancer patients. Clearly, the data suggests that. So I'm going to wrap up with training programs and serious illness conversation guide, which I alluded to in my question. This is, I moved away from this one of the years I did this talk, and I'm coming back to it just because we found that, doing role modeling of you going in, probably a lot of you have done this, where you have the actor as your patient, and you go in and you go over prognosis or have a serious illness conversation with the patient. And the data supports that these do work and that they do help. So we're currently at Penn being trained on this. Corey, have you gone through this training yet? Serious illness conversation guide? Not yet. Okay. So a lot of us have so far. They're starting with lung and colorectal because apparently we're the doomsday cancers. So they're starting with us, and this is absolutely evidence-based. So this is Bernanke and Susan Block out of Mass General, or Brigham and Women's, sorry. And this was developed, and it's actually just a guide of actual statements you make. I go into a room with a piece of paper on a clipboard, and I read the questions. And I tell that some patients ask me to see them before because they don't want to enter the conversation without knowing what they're going to be asked. But this study has looked over these statements and shown that they are beneficial and accurate and a good way to begin to talk about things with patients. So this is the guide. So again, developed by literature review and experts. You set it up by introducing the patient. I'd like to talk to you today about what is ahead with your illness, and then ask, is this okay? Really important to ask, is this okay that we discuss this? And I put this in mind as opposed to Dr. Temmel's talk because I do this early on. This is not anything later on. And she's going to tell you, too, that earlier on end-of-life conversations are better. But I don't consider this an end of life. I consider this I'm just getting to know you. I'm just getting to know you and, what your goals might be. So if they say it's okay, the next thing is to introduce the benefits. The goal is to make sure that I have all of the information I need to know about what matters to you most. And then the guide says, what is your understanding now of where you are with your illness? You get so much information back from a patient when you ask this question. It's unbelievable. I've done this 4 times now, and it has opened up a world of patient-nurse practitioner relationship with us. It's amazing. I thought this would be so hard, and it's actually the easiest thing I do. It's a great conversation as long as you have time for it. And by the way, you get extra RVUs for this. So you can bill for this. How much, and then the next thing is, how much information about what is likely to lie ahead with your illness would you like from me? And I've had varying degrees in my 4 patients. Some say, I want to know everything. Some people say, I don't want to know anything. I only want to know the bare minimum of what you have to tell me. And other patients say, Beth, you tell me every single number and every single thing that I can possibly do. So then you just get an idea. The next thing, share your understanding. So you actually say, can I share my understanding of your illness? And usually they'll say yes. I had one patient said no. So, okay. But if they say yes, then you can say, so what my understanding is that we've done a chemotherapy regimen, and now we're on to the second-line treatment, and then go from there. You talk about goals then. If your health situation worsens, what are your most important goals? And then you keep going on. If you become sicker, what are you willing to go through? The one thing here, too, is that it's important to pause and give lots and lots of time for patients to process each question. So that was the one major thing in this training session, is they said, pause. just be quiet, awkward silence. I hate that. I'm from the Northeast. I like to talk constantly. It's so uncomfortable for me. It's so uncomfortable. But that's what they say. Pause and just be quiet in the room and let them process. It's almost like a staring test. Who's going to talk first? I just said what your prognosis is. See? Totally awkward, right? And then it's okay to use the I hope, but I worry. And I know Dr. Temmel had this in one of her questions too. I think I use this statement at least once a week. And it's okay to say that because you're hoping with them, you're aligning yourself with them, but I worry that because you're getting short of breath and you're not walking like you used to, that something could happen. And that opens up conversation as well. So my conclusions are, there are several barriers that exist to prognosis discussion, not only with physician-patient, but with consumer advertising. Make your cancer go away. We will make your cancer go away. So there are barriers. When discussing treatment expectations, simplify. No PFS, OS, and bevacizumab all over the place because they're not going to understand what you're saying. Facilitate discussions with using a guide or however you want to do it, and facilitate that relationship. This serious illness conversation guide has really, really helped me to be able to facilitate that relationship with the patients, and I feel like I know so much more now. And their family members too, because their family's usually in the room, and I always see their eyes brighten up like, oh, I didn't know that. So it just helps so much with that. Okay, thank you so much for listening.